About breasts today. Um, as always, feel free to interrupt and we can jump down rabbit holes because if anybody knows this by now, I love jumping down rabbit holes. Okay, tangents, that's what I'm made of. Why don't we just jump right into it? You guys can unmute yourselves, talk amongst yourselves about this little case in front of you. There are two kind of questions to think about or answer. So yeah, let's have a little lively discussion. We got a patient in front of us. Pretend you're in JHAP, set the scene, set the mood. You're in JHAP, you get this, nice young lady. She's coming by to see you, establish care. The details of her case are listed above in those first 4 points. The first thing that she tells you is, she's got this little lump in her left breast. It's been unchanged, it's been there for a few months, no nipple discharge or any other kind of symptoms. What do you do? What are you going to tell her to do? And question 2 really just is asking you to show your work. When you decided what to do, what did you think about? So go ahead. I can make breakout rooms as well if you guys want. It's up to you. Or I guess Nick can, because I don't think I have the ability. I'm not that.
I do not have that power.
So I think I would first do a mammogram. She's over age 30, so I think usually it's a mammo plus or minus ultrasound, and then it also looks like she was pregnant, but that was a long time ago, so that doesn't seem to be like a block duct or anything, like if it was a recent pregnancy or she's currently lactating. So given her age, I think I'd probably do the mammo plus or minus the ultrasound then.
Okay. I like it. I like your thought process. Anybody else? Anybody else have any thoughts? Conflicting opinions? Doesn't seem like it. Okay, we're all on the same page. We're all thinking probably a mammo plus or minus an ultrasound. Okay. And then I think Mike alluded to them, but so one of the factors that you were thinking about is pregnancy, you said. How did that, or if anybody else has a thought, how did that kind of change what you were thinking about?
You can't do a mammogram in pregnancy, right? You would do an ultrasound.
Okay, that's a good thought. Is a mammo safe? It is essentially, like X-ray imaging. So there's some radiation exposure, but it's pretty minimal. For the most part, we try to avoid like screening imaging in somebody who's actively pregnant if we can wait. I would say another thing to think about is, the mass, could it be related to the pregnancy? More of like changes, like hormonal changes. And then I think the other part to think about when it comes to pregnancy, and in addition to pregnancy, questions to ask can include like, when was your menarche? And then for postmenopausal women, when was your menopause? And in addition to that, there's other risk factors that she has where she was like a smoker and that kind of thing. And then her obesity. What we're getting to here is also her like cumulative risk factors for breast cancer. Some of them increase risk, some of them decrease risk. So we'll get to that. But for now, I just want us to start thinking about that. To answer the question, you know, it's a little bit interesting. Mike is you know, very much so correct. Usually, when we think about like imaging modalities, right? Especially when we're trying to answer like board questions or what type of like, you know, screening to get for the patient in front of us, there's a few options that we think about, right? There's the MRI of the breast, there's the ultrasound of the breast, there's of course your mammogram. And then I'm sure that some of us have seen this. It's like kind of essentially a mammogram with like uh, tomosynthesis, right? Those are kind of our four options. So let's talk about all of them. The first one to think about, of course, the most commonly used is our mammogram. The mammogram has lots and lots of great data, right? So very high quality data, and it basically tells us it's pretty sensitive, and it does actually do lead to reduced mortality when used in a screening sense, in a screening case. When it comes to this, when it comes to the mammogram and its high false positive rate, is actually why both the USPSTF and I believe the ACP recommend Q2-year screening. Conversely, does anybody have an idea or how much do they think the false positive rate will increase if you did yearly mammo? It's not anything to scoff at. So it can actually increase the false positive rate by anywhere between 30 to 40%, which is, you know, about a third of cases are going to be false positives, which is why the recommendation from the, you know, ACP and USPSTF are Q2 years. The Gynecology Society and some of the cancer societies still recommend Q1 year though. And this has led to kind of like an increased prevalence of breast cancer, you know, because we're diagnosing it earlier. Okay, I think the difference between like, you know, why don't we just get an MRI in everybody? There's no radiation, and you know, it's a higher resolution. You know, the reason for that is, of course, as it always comes down to, especially for screening, is going to be your cost, right? It's your costs. It's expensive. And then there also isn't any very like good, robust data for screening everybody in the population with an MRI. The data that we have is that essentially for patients who have a really high pretest probability, you know, so somebody who's very high risk of having breast cancer. So what are some patients that you would think of that would have a really high risk for breast cancer? And of course, one of them is listed over here, right? So your BRCA positives. But along that stream.
Family history.
Yeah, I agree. You know, other inheritable, you know.
Lynch.
Yeah, okay. Lynch syndrome. Cowden's is another one. Lee from any, which is like the P53, you know, single mutation. So all of those kind of like inherited diseases, people with a really strong family history, despite not having BRCA, are still somebody that our pretest probability is super, super high. So I think it behooves us to do two things, right? Start screening earlier and start screening with a more sensitive tool, because we want to pick up even the smallest lesions. Okay. And then there's ultrasound, and you might be wondering, well, when do I use an ultrasound? The best use for an ultrasound that we have is in women younger than 30. It's typically the like, you know, first pass answer for when they have a mass. So they have to have a mass and be under 30 when you're thinking about doing just an ultrasound. In people who are between 30 and 40, so pertaining to our question that we had, we want to do an ultrasound and a mammogram. So you want to actually do both. The reason for this is the ultrasound is going to help with identification of the mass itself, but the mammogram is going to help us pick up microcalcifications and involvement in both breasts. So for these patients that kind of fall within that like window between 30 and 40, it's probably useful to do both of them. And if they're above 40, it's probably, you know, you're going to lean towards still probably doing both with an ultrasound for the mass itself, but there's even more evidence to do like the mammogram. All right, and then I only included this because I think it's one of those things that like we see all the time in like our orders, and you know people use it like as like a resulting thing. Like essentially, what a tomosynthesis is, it's like if anybody's familiar with our like you know surgical department here with like the CT abdomen like YO protocol, where they just basically all they really do is they take the structures that they collect from a mammogram and they make like a 3D image of it. There is no current like evidence to say that it's better than a mammogram that's like very robust. So, and it does cost more. Usually most places like, you know, like for example, like Jefferson, they do this like anyways. But for now, like when you get it in your board questions and you see it as an answer choice, you know, I would pick mammogram over the tomosynthesis whenever possible. Okay, so hopefully I think we have a good idea of what all the different like kind of imaging options are. And I think what we can realize is that when it comes to screening, you know, we have a couple of options, right? Like there's mammogram and there's MRI at the end of the day, and then we're trying to decide who gets what. So let's again think about some of the risk factors for breast cancer. And this is kind of like how I think about it. You know, there's a lot of different ways to think about breast cancer, but the way I think about breast cancer is it's almost essentially, it's directly proportional. So your risk is directly proportional to your exposure to estrogen. And in any woman's life, their exposure to estrogen, at least an exposure that would be above that of a man, would start increasing after menarche, right? And will continue until menopause. So looking at this graph then, what do you think, and during this, in this in-between time, you know, almost like sun rays, like during all of this period of time in their life, they're getting constantly exposed to estrogen. So what do you think could possibly decrease their risk of estrogen exposure?
Pregnancy.
What was that?
During pregnancy.
Yeah, exactly. So that's definitely one. So if, during pregnancy, it almost gives you like a reprieve, right? Like a nice little 9-month break from estrogen. Because during pregnancy, your predominant hormone is actually going to be progesterone or whatever. So it's like a nice little reprieve from estrogen exposure. So that's nice. What about your menarche? How could that influence your risk of breast cancer? Or
Later
menarche?
menarche.
Yeah. You are muted, Andrea.
I said later menarche. Oops.
Oh, okay. Sorry, I misheard you.
No,
Yeah.
no.
So it like you know essentially if I bring this line, this cutoff right here, if I make it earlier in time, then I'm exposing them to even more estrogen. So I have increased my risk here, right? If I move it earlier. If I move my menarche later, so let's say this was at age like, I don't know, 11. And then if, let's say somebody had menarche at age 15 for whatever reason, then they lose this time of estrogen exposure, and that would decrease my risk. Same thing for menopause. So if this is all estrogen exposure here, if I have early menopause, what do you think is going to happen to my risk of breast cancer? I'm seeing some hands like, sorry, I think maybe Fred, I kind of heard you. But yes, exactly. So, you know, early menopause. So if let's say this lady was supposed to get menopause at 50, but then she ends up having it at 48, that's 2 years that she got to save from an estrogen exposure perspective. And so this is going to decrease our risk. And if you, conversely, if you have late menopause, if she ends up having it like 52, then that's 2 extra years of estrogen exposure. So this is all estrogen coming, like raining down like, you know, sun rays on the body here. So if you add 2 years of estrogen exposure, then this is going to increase our risk. At least this is how I like to think about it. And when it comes to sources of estrogen, let's also talk about this. During this period of time, from your menarche all the way to menopause, the primary source of estrogen is what? Where does all your estrogen come from? Your diols, your triols, where are they coming from?
Ovaries, usually.
Yeah, ovaries. So much estrogen comes from the ovaries. What about in this stage? What about after menopause?
Isn't it usually like adrenals and partly fat too?
Exactly. So the primary source of estrogen here is your adrenals and your adipose. And they both use a nice little enzyme that we're going to get very, very familiar with. Aromatase. Smells very nice. Aromatase. Look at that. Adrenals, adipose, aromatase. So easy to remember. You'll never forget that, right? So essentially, you know, the source of your estrogen does change. And you can assume then in people who have a lot of body fat, a lot of adipose, are also going to increase their risk. So this is kind of how I think about estrogen risk. And you can see that it can become kind of like a complex interplay between a lot of different factors, right? Especially with breast cancer. And the reason for that, even if you're wondering, like, why is it so closely tied to estrogen? And that's because about 70 to like maybe 75% of all breast cancers are actually hormone positive. So you can see that exposure to estrogen is going to just, it's a growth factor, so it's just going to help the cancer grow. And since the majority of breast cancers are, you know, hormone receptor positive, they're going to become, you know, bigger and more malignant. So that's why this is all important to us. Here's a summary of everything that we kind of really talked about, including like other factors. But you can see that it becomes like kind of complex, right? So here, increasing risk, obesity. Why? Because it increases the estrogen from adipose tissue, right? Age. Why? Because the older you are, the more estrogen you're going to be exposed to. Early menarche. We talked about this too, right? Because it's longer duration of ovarian estrogen exposure. Late menopause. Same reason. You're extending the time you get exposed to estrogen. And for decreasing risk, we also talked about this, both parity and even breastfeeding can decrease your risk because they're going to decrease your estrogen exposure. Okay? All of these.
What's the aspirin about, Navi?
What's that?
What's the aspirin about? I've never seen it.
There's this like, I think there were a couple of studies when I like first made this lecture that are pointing to that possibly like aspirin intake between the age of like, I think it was 40 and 50 could be linked to a decreased risk of like breast cancer development. But the subsequent studies haven't really proved that. So that's why there's a question mark there. It's like, do we need more studies? And then,
What about inactivity?
Sorry?
I mean, outside of obesity. Like, is inactivity an independent risk factor, or is it more just that if you're inactive, you're more likely to be obese, et cetera, et cetera?
The latter. You know, people who are inactive are more likely to have what's the word I'm looking for? Obesity, and then you know, like heart disease and all that other stuff tied to it. And then when it comes to other risk factors that like we kind of have to know about, of course, there's genetic risk factors that we already talked about, right? Like BRCA, Cowden's, Li-Fraumeni, Lynch syndrome. This one I think makes a lot of sense too. Anybody who's gotten chest radiation in the past is going to be at very high risk of developing breast cancer. So these are patients that to look out for, especially in our clinics. They're going to be people who are like maybe like survivors of lymphoma, especially like Hodgkin's lymphoma. You know, they get chest radiation for whatever reason. We need to think of them as really high risk for developing cancer. And then if they don't fit into a genetic bucket, but they have a family history of somebody having breast cancer under the age of 50, just like we think about for our colon cancer patients, you know, we need to start screening these patients at like an earlier age. And then this last group is, you know, people who have known history of some sort of like essentially, you know, lobular carcinoma in situ, atypical hyperplasia, those kind of thing, that is also going to increase the risk. So again, summarizing all these risk factors, like I was saying in that first slide, you know, it can become, a very, very complex interplay, right? Some factors increase risk, like, you know, how are you going to counsel somebody who's had, you know, multiple pregnancies, but they had early menarche and they're obese. You know, like they've got a lot of different factors that kind of combine together. So how are you going to decide for them what their overall risk is and go from there? So here's, for some of you who have gotten my answer before, I'm thinking that there's at least going to be one or two of you out here that thinks about, you know, the like kind of combination of both the factors that increase risk, decrease risk. This is going to help us, you know, shape how we not only screen our patients, but even how we treat them. And what I mean by that is, you know, there exists tools out there to help you make this decision. So what I'm talking about here is something that, again, some of you might be familiar with, but it's like this Gale model. I'm going to point out this one over the Tyrer-Cuzick, and that's because it's much, much easier to use. You know, it takes about 30 seconds. And what this model, all this like calculator does is it will, you know, ask you based off of all of the patient's risk factors, you know, in anybody who's over the age of 35, as long as they don't fall into these like high risk categories, what is their 5-year risk of developing breast cancer? So it's going to be able to account for all those factors. And then depending on that risk, it does tell you, could they benefit from chemo prevention? Does anybody know what I mean by that?
Like tamoxifen?
Yeah. Do you want to tell me a little bit more about that, Ellie?
I know that it's like it's supposed to help reduce your chance of developing breast cancer, and you use it only for a period of time, and then you are supposed to have like protection after you use it for, I don't know, 10 years or something like that. I've never actually seen it prescribed, but apparently it's supposed to be by the guidelines if you're greater than 5% risk, or I think that's what it is, in a 5-year period.
Yeah. So yeah, we'll clarify some of the numbers there, but that's essentially in a you know, a gist of what the Gale model is telling us. It's going to tell us the 5-year risk of developing breast cancer. Our cutoff is roughly 1.7%. So if our 5-year risk is greater than you know, 1.7%, these patients will benefit from, you know, something like tamoxifen. And if it's less than 1.7%, they do not. And you might be wondering, like, what? We're going to give somebody who doesn't even have breast cancer tamoxifen? So the reason is, of course, you know, their risk of breast cancer is really, really high. But in addition to that, the benefit is actually pretty good too, because these patients actually, their 5-year risk of developing breast cancer can go down by as much as 65%. So it's not nothing to laugh at, you know, as long as they don't have reasons to not get those interventions, they'll probably benefit from it. Okay, so let's very briefly talk about some of the options for chemo prevention. There's tamoxifen, there's and then there's your aromatase inhibitors, which include anastrozole, letrozole, and exemestane. Okay. Both tamoxifen and raloxifene are considered like SERMs, if you guys remember that, right? That means that they're selective estrogen receptor modulators. So they like block the estrogen receptor in the breast. Oops. But they actually will increase estrogen exposure in like something like the uterus. This is bad. This is good. Given that it can, essentially act as estrogen, what are some of the risk factors that we always think about? What are some of the side effects that we think about when starting tamoxifen or raloxifene?
Clots.
Yeah, okay. So if we think about, this is the mechanism, contraindications. So yeah, definitely DVTs. And along that line, PE or stroke. Remember, they're all really thromboembolic, right? And in anybody who has an increased risk already of endometrial cancer. So these are kind of contraindications. These are people that, we're saving them from a theoretical benefit from breast cancer, but then we're going to give them the risk of endometrial cancer. So that's definitely something to think about, especially in somebody who has risk factors for that. Raloxifene, so osteoporosis is another like risk thing that we think about, but raloxifene is slightly better than tamoxifen in patients who have like a risk for fractures or osteoporosis. But tamoxifen has better data than raloxifene when it comes to chemoprevention and stuff like that. So that's why it's still considered first line. And then your aromatase inhibitors, when it comes to the SERMs, do they also have risk of like DVT, PE? What's a contraindication for using an aromatase inhibitor?
If they're if they're premenopausal.
Yeah, so that's definitely a good point. Remember that they inhibit aromatase, and that's mostly your adrenals and adipose, right? So in people who are premenopausal, the source of their estrogen is ovarian, and that doesn't really play a role. So that's why it's not useful in premenopausal. You only use it in postmenopausal women, whereas these two you can use in premenopausal.
Navi,
yep.
for tamoxifen, if you have patients who are high risk for either developing osteoporosis or for developing like their osteopenia, and now we start them on tamoxifen, do we ever just prophylactically start putting them on like osteoporosis treatment?
That's a good question. I think currently guidelines would actually tell you that these are patients that you should monitor. Now, if you're doing tamoxifen for chemoprevention, usually these are patients that are younger. So the chemoprevention age cutoff is typically somewhere between over the age of 35. And something that I think I may have forgotten to mention that Ellie sort of talked about is you do it for a total of 5 years for chemoprevention. So yeah, this is always only like a total of 5 years that you get tamoxifen or raloxifene and all that stuff. So their risk of developing like osteoporosis over 5 years is usually on the lower end, unless they're like already like postmenopausal and they're taking an aromatase inhibitor, because an aromatase inhibitor actually has increased risk of osteoporosis compared to tamoxifen and raloxifene. And since they're postmenopausal, you're probably targeting an older population. So these are the patients that actually might benefit from doing early DEXA scans. I hope that answers your question. Other than osteoporosis, the other like need kind of thing that they check you on for aromatase inhibitors is that they increase your risk of arthritis. You get a lot of arthritic pain. Okay. This is, of course, my usual typical garbage handwriting, so I did make a nice, neater table for you guys as well. Okay. And now combining everything that we learned about for screening and risk factors, you know, and use of like tamoxifen, raloxifene, and everything, let's come up with a little quick algorithm, right? So any female patient, first question we ask ourselves is, do they have risk factors for BRCA, ductal carcinomas? Do they have a strong family history? Do they have known family history? Do they have a history of radiation therapy? If the answer is yes to any of these, you can't use the Gale model because they're already high risk. The Gale model is only for average risk. So now that we know that we can't use the Gale model, we then just subdivide it into each group that they belong to, right? So if they have this history of LCIS or AH, the prevalence of having hormone positive here is around like 80%. So these patients typically do benefit from just getting that 5 years of tamoxifen. And in addition to that, since they're considered high risk, remember our high risk population is the one that we actually want to use mammograms on. So these are the people that you're going to get this yearly mammogram. If you have a BRCA history, again, definitely need that yearly MRI and mammogram. While we're here on this BRCA history, I just wanted to tell you about my rule of fives, that like how I remember BRCA stuff. So 5 times 5 is 25. That's how I remember. MRI is always at age 25. That's when it starts. Add 5 years, that's when you add the mammo. So that's at 30. Add 5 years, that's when you do prophylactic mastectomy and oophorectomy in BRCA 1. And then add another 5 years, that's when you do the prophylactic surgery for BRCA 2. So it's 25 MRI, 30 mammo and MRI, 35 prophylactic surgery for BRCA 1, 40 for prophylactic surgery for BRCA 2. I hope that made sense to at least one person out there. But that's my little rule of fives to remember the age cutoffs for like your BRCA patients. Okay.
Navi.
Was there a question?
No, I said I loved it.
Oh, rule of fives. And then so in addition to that, you know, they may not fall into these buckets, right? These BRCA family, like, you know, Cowden's, Leafermania, all that stuff. They might fall into this bucket that of where they have this cumulative risk factor of breast cancer, you know, lifetime risk of 20%. So this is not like a 5-year risk. This is a lifetime risk. And these patients, since they're super high risk of developing breast cancer, they also need an MRI. It's unclear if they benefit from tamoxifen, though. So you won't be asked about this, but you could be asked about what are you going to screen them with. And then, of course, our patients with chest radiation. This number I only remember because it's very similar to like when do you start checking for like yearly colonoscopies in our patients with ulcerative colitis and that kind of thing. So anybody who got chest radiation, you start getting your yearly MRI 8 years after radiation. So it's like, that's how, I don't know why, that's how I remember it. And they do not benefit from tamoxifen. As a kind of like bridge all for these patients, the way I think about it is they all get yearly mammo and MRI for this population. The age cutoff might be different, but they all get yearly mammo and MRI. Now, conversely, if you don't have this like strong family history or strong like risk factors and you're average risk, this is high. High, that's why it's higher up. This is when you use your Gale model. And then you decide based on, and this is where you get that complex interplay of factors that both increase or decrease risk. And this is where you can then decide based off if it's greater than 1% and they're premenopausal, then you use tamoxifen. If it's greater than 1.7% and they're postmenopausal, you use an aromatase inhibitor. And of course, if their risk is low and they don't have risk factors, then these patients are not going to benefit from tamoxifen. As for screening for them, these are our typical guidelines of using a mammogram only, typically at least in these two patient populations. In these premenopausal, you can consider doing a mammogram at age 40 Whereas these ones, you know, you're typically going to start 50, you know, this postmenopausal anyways. I hope that makes sense for everybody. All right, let's switch up gears a little bit, and do a question. I'm going to read it because I love the sound of my own voice, but I want everybody to be thinking about it, okay? 32-year-old, she's coming in. Yay, she has breast cancer. So we talked about all the stuff before a diagnosis of breast cancer is made, right? We already talked about that. We talked about screening. We talked about chemo prevention. We talked about risk stratification. We really beat that to death too. Now we actually have a diagnosis of breast cancer. How do we treat that? And that's kind of like what the latter part of our conversation today is going to be. I hope I have some time for this. So again, 32-year-old, she has breast cancer. Oh my God, stage 3A. What does that even mean? She's ER positive, PR positive, HER2 negative. She has 4 axillary lymph nodes that were positive as well. She completed neoadjuvant chemo, a lumpectomy, an axillary dissection, and got breast radiation. After all that was said and done, menses started up again, huzzah, and her estradiol levels are in the premenopausal range. Ooh, interesting, very complicated. Physical exam, whatever, doesn't matter. What are you going to treat her with, you oncologists? Tell me what you got. What are you thinking? Let me hear from you. Ah. Ooh, there's a chat. Oh my God. All right, I got some votes for baby D over here. Anybody else? Let's see by show of hands. I'm gonna do this thing. Who says A, aromatase inhibitor? There, people are actually violently shaking their heads to that one. Who says B, leuprolide? Okay. Who says C, leuprolide and an aromatase inhibitor? Got a few votes for that. Okay. Oops. And then D, tamoxifen. Got a few votes for that. So we're pretty split on tamoxifen and leuprolide. Somebody who said tamoxifen, tell me what you're thinking.
It's, at least my thought was that so an aromatase inhibitor itself is not going to do a lot because she has another source of estrogen, her own ovaries, especially since she's menstruating again. Same for leuprolide. Leuprolide by itself isn't going to do a lot because then you still have to take care of the aromatase estrogen. My thought, I honestly I was kind of between the two, and my thought was that tamoxifen is acting a little bit more directly.
Okay.
So maybe you would have fewer side effects and more like actual treatment effects.
Yeah. Let me throw this back at you, and you kind of talk. Let me think to all of you in the beautiful electronic world out there. Let me ask you this. In your mind, after reading her history, do you think that she would be high risk for recurrence or low risk? Who says high risk? Hands up. Who says low risk or average risk? No one. So you all thought she was high risk, and I agree with you. She's young. She already had stage 3 cancer. It was horrible. So her risk is really, really high of recurrence. And then ask yourself, which one of these treatments is actually going to shut off all the estrogen everywhere, right? Aromatase inhibitor, like you said, very astutely, is not going to stop the ovarian source because she's premenopausal, right? So this is not the right answer. I agree. This is not enough estrogen blockade. Leuprolide, if those of you who may have forgotten or get confused, because I always do, you're like, wait a minute, isn't that a prostate cancer treatment? All it does is it's a gonadotropin releasing hormone agonist. So basically, by increasing the GnRH, you're going to lead to increasing your your sex hormones. So like things like estrogen. Oh my God, that sounds horrible. But then what happens is that there's a feedback and this eventually does get shut off. But in the short term, it's going to actually increase estrogen, right? Or testosterone. So that's kind of like how leuprolide works. So then what if you gave, an ovarian inhibitor and then at the same time gave an aromatase inhibitor to shut off aromatase, so you're not making any estrogen from your adipose, you're not making any estrogen from your adrenals, and then you're also not making any estrogen from your ovaries. This patient is not going to get any estrogen anywhere, right? So that's why the actual correct answer, and just so you guys know, don't feel too bad, only about 17% of people got this right. Most people did think that the answer was tamoxifen because we saw premenopausal, but in reality, because of this really recent trial, it's called the SOFT trial, which is suppression of ovarian function trial in breast cancer. This is what showed that the combination of an aromatase inhibitor plus ovarian suppression. So this means either like surgical or medical suppression. It leads to an increase in overall survival and decreases your recurrence in patients, even more so than like a tamoxifen plus an ovarian suppressant. So when it comes to like endocrine therapy in patients who have known breast cancer, it's actually quite a simple algorithm. We still do think, first question is, are they premenopausal? Are they postmenopausal? You know, that's the first question. Now, though, the only complicating thing is if they're premenopausal, we still have to decide, are they high risk? And the way I decide if they're high risk is, did they get chemo? That's all you really need to know for our purposes here. If they got like neoadjuvant or adjuvant chemotherapy, as a reminder, neoadjuvant means before surgery, adjuvant means after surgery. So if they got chemotherapy, you can probably assume that they were high risk, you know, especially for our question stems, and they're going to benefit from this like SOFT trial, like aromatase inhibitor and ovarian suppression. And if they're low risk, so these are patients that just got surgery, they didn't need chemo, they just get tamoxifen. And notice that the duration is different too. These patients, they benefit from 10 years. And remember that's different from our chemo prophylaxis because that was only 5 years. If you're postmenopausal, that's easy. Everybody just gets an aromatase inhibitor and they get it for 10 years. Okay.
Navi, question.
Yes.
What if that patient said she wanted to get pregnant? Are you supposed to advise them not to?
That's actually it's a really good question. And honestly, as a primary care physician, it's going to be difficult to answer because I would say, like personally, and I think that most oncologists would agree that they would probably advise them not to get pregnant because their recurrence rate is so high. You know, she is 32. If she's saying like, you know, this is my only shot, like, can we delay this by like 9 months or whatever? That's going to be a conversation that you're definitely going to want to involve the oncologist to comment on their recurrence risk, like more definitively with the patient. But if she did want to get pregnant and she's adamant that she wants to get pregnant, then this is probably somebody who I would think like, okay, then post-pregnancy, let's just cut out your ovaries. Like, let's do a surgical intervention so that you can get like a more direct benefit instead of doing 10 years of like cumulative risk reduction with like tamoxifen and stuff like that. And of course, then that the surgery would be post, pregnancy. But that's a great question, and I think it would be difficult for us to answer without all the information. Okay. The final part of our conversation today, and I know that we're already over time, but I wanted to make sure that you guys got exposed to some of these slides because there are going to be questions about this as you work your way through MixApp. And I also know that, we're basically have a snow day today, so I kind of have you like captured. I'm going to keep going, but if you have like a patient to see, please, I won't be offended if you want to like leave, go right ahead. Those of you who want to learn more about chemotherapy and treatment of breast cancer by stage and that kind of thing is what we're going to talk about next. I figured it would be a good idea to keep talking. Nick can stop me if he wants to, but I figured if you're going to upload this on YouTube, we might as well get everything. And then, so for those of you who have to leave, just watch the lecture on YouTube. All right, so let's keep going. And again, leave if you have to. Okay, so this is my like summary slide that we're gonna come back to, and you do not need to like, this is for you guys to like see and like screenshot or whatever if you want to save it. But so because you can see that there's a lot of decision making that goes into breast cancer, and and it's different according to like what stage they are, and then it also will be different depending on whether or not they have hormone receptor positive, how many lymph nodes are involved, and all that stuff. And these are, of course, general approaches. So in patients who have, and we're going to go into more detail as we continue, but this is, again, like a summary exposure to all the stuff, and then we'll come up with an approach. So in patients who have like LCIS or DCIS, this is kind of like called stage 0, I guess you could say. So they're in situ cancers, right? Anybody who falls into the LCIS, DCIS, or stage 1 or 3 can theoretically, these patients can both be cured. And remember, when you go through this chart and the rest of the lecture, remember my golden rule. Radiation and surgery are intent to cure. Chemotherapy is typically not an intent to cure. It's either to get rid of like micrometastases or as a palliative approach. So chemotherapy is going to be much more of a mainstay in these later stages, but up here, the primary treatment is always going to be surgery. And in stage 3, it's probably surgery. In stage 4, it's like never surgery. Okay, so when it comes to surgery, there's 2 options, right? There's lumpectomy or mastectomy. And what you really need to know is everybody gets a lumpectomy unless they can't. And so if you're wondering about who can't get a lumpectomy, it's patients who have lots of lymph node involvement or a really big cancer. Those are the first 2 things that we think about. So lumpectomy before mastectomy, and the reason for this is because mastectomy, especially in these locally like seen tumors, there's no survival benefit, and there's really not much of an overall like recurrence rate benefit as well. So we switch to mastectomy if it's really big, so it's over 5 centimeters, or if there's greater than 4 lymph nodes involved. And both of these cutoffs, you're going to see time and time again. You're going to keep saying them time and time again. And guess what? That automatically places them in stage 3. You're going to see that again and again. Greater than 5 centimeters, greater than 4 nodes, automatically makes this stage 3. So if they're stage 3 breast cancer, they need a mastectomy. That makes sense. If they're stage 1, 2, LCIS, DCIS, they're going to get a lumpectomy, right? Other things to think about that are less commonly like known, but inflammatory breast cancer or breast cancer that involves the skin. These are 2 cases where you always get a mastectomy as well. And you always get a mastectomy if the cancer is invading like other structures. So even if it's like 4.5 centimeters, but it's invading into like the pectoral muscle or something like that, then that's a patient that you're probably going to do a mastectomy on. The reason for that is you think of that as high-risk features, right? Okay. Now that we've decided who gets surgery, let's think about who gets radiation. It's actually kind of nice because anybody who gets a lumpectomy also gets radiation. Essentially. Anybody who gets a mastectomy, for the most part, also gets radiation. The cutoffs that they give you, and we're going to talk about this later too. So anybody who gets a lumpectomy or nodal disease, they're going to get radiation, right? Lumpectomy, nodal disease. The patients who possibly couldn't get radiation, the only ones are really like our DCIS and LCIS patients. So if they have like this in situ cancer, you do a biopsy, you get the whole thing out, the margins are clear, they have no lymph nodes involved, right? These are patients that are considered like kind of low risk, so they don't need radiation necessarily. But everybody else who actually has invasive cancer, so anybody who's like stage 1, 2, 3, they're going to get radiation. Okay. So that's kind of who gets radiation and who gets surgery. Let's think about who gets.
Navi, question on
Yes?
that? I feel like I see a number of patients who might have DCIS or LCIS, but because they're worried, they end up choosing to get a mastectomy anyway. In that situation, do they still, like, if you had more surgical treatment than was necessary, do they still need post-op radiation?
So, right. So again, it would be, for those individual patients, my thought process is probably after discussion with their oncologist or surgeon, and based on the histology of the cancer itself, they probably thought it was a high risk DCIS or LCIS. So maybe it looked really big, or it was very like early invasive kind of thing. And so because they were concerned about the high risk, and that also not only be based off of the histology, but also based off of the patient's history, like if there's somebody who has a history of breast cancer in the family and all that stuff, with that complex interplay, I don't think it's unreasonable that some patients might get a mastectomy, with DCIS or LCIS. And then when it comes to their radiation, again, since they got a mastectomy, we're defining them as high risk, so they're probably going to get radiation. If we're going to go to the point of like doing a mastectomy because we're worried about the recurrence risk, then they're probably a patient that's also going to elect to get radiation therapy. The other thing that I think that's good enough. Okay, any other questions about that, about radiation surgery, who gets what?
No, thanks.
Okay, all right. And then when it comes to, let me think about this. The only other thing, so when it comes to stage 4 disease, it's very different. The treatment of stage 4 disease, since there isn't really that role for primary cancer, surgery or radiation with a definitive intent to cure, instead, all we have is palliative chemotherapy. Essentially in patients who have like DCIS, LCS, and even up to like stage 2, anywhere from like 99 to I think about 95, maybe as low as 90% of these patients, get cured, and only like less than 5% recur after 5 to 10 years. In these patients, it's very, very low. In fact, in stage 4 disease, I believe it's the 5-year survival for stage 4 disease. So this is our stage 5-year survival is only about 22%. And the mean, I think the average survival is only about 2 years. I only remember because it's all 2s. So this is a very aggressive cancer. It's very incurable. That's why we do our best. That's why we are so aggressive, because we want to prevent anyone from progressing to stage 4 disease. Because stage 4 disease is horrible, and we don't have a lot of good treatment for it. When it comes to stage 4 disease treatment, of course, our mainstay is now going to be chemotherapy. We'll talk about what the options there are. And then there's a lot of modifiers. So if patients have ER positive or PR positive disease, then they're going to benefit from an aromatase inhibitor with palbociclib. If you guys don't remember what palbociclib is, it's our CDK, I think 4 and 6 inhibitor, and then an mTOR inhibitor like everolimus. So this is very complex. The only reason I brought it up is because it's weird and different. And so if treatments are weird and different, that's when the boards love to get you on it. And that's why MCSAP likes to ask about this one. So we will talk about this in more detail. And then if there's bony disease, these are the patients that are going to benefit from things like bisphosphonates, PARP inhibitors, that kind of stuff. Okay, let's think about an approach though. So that was a general overview. Let's think about an approach. So when you're evaluating either a question stem or a patient who has breast cancer, here is Navi's patented stepwise approach, okay? The first step you should always do is stage the patient. The second step is see if they're a surgical candidate. Third step, see if they're a radiation candidate. Fourth step, see if they could get a HER2 blocker. Fifth step, assess for hormonal therapy. And then the last step, assess for chemotherapy, either both for adjuvant or like kind of first line. So let's talk about that in a little bit more detail, right? So first step, stage. And then, staging the patient can be relatively straightforward. So stage 1 to 2 is easy to remember for me, at least, because I always remember stage 3. This is greater than 5 centimeters or greater than 4 or more lymph nodes involved. I always remember stage 3, and that's how I remember stage 1 or 2, because that's less than 5 centimeters. And then, less than 4, so like anywhere between 1 and 3 lymph nodes involved. Oops. And then stage 4 disease is any MET. If they have a distant MET, but they don't meet these criteria, it doesn't matter, right? So that's how I very quickly define stage 1 to 2 to 3 to 4. But and really the only one that you need to remember is stage 3. Sorry, my handwriting is so bad. Is any cancer tumor that's greater than 5 centimeters or more than 4 lymph nodes. So if you know this cutoff, you can derive the other 2. Okay, so then depending on the stage, our surgical evaluation changes too. So lumpectomy is if you're less than 5 centimeters or less than 4 lymph nodes. Oh my God. Those are the same cutoffs as stage 3. So again, that's really the only one that you have to know. So I'm trying to make this as easy to remember as possible. Mastectomy, if they're greater than 5 centimeters. If they're greater than 4 lymph nodes. Other things to think about here are also if they can't get radiation. So if you can't give them radiation, then you should just do a mastectomy. Or like we said before, if they have like skin involvement, if they have like weird forms of cancer, like inflammatory, these are patients that are going to benefit from mastectomy. This is a question that we haven't necessarily covered yet, is who gets this axillary lymph node dissection, if anyone? And this, we'll go off the deep end here too. The first thing to think about, so maybe I'll draw a little picture, but so if this is like a breast, and this is like your axilla. So this is my axilla here. This is my breast here, middle. So let's say we have like a mass here. Ah, it's scary. The sentinel lymph nodes, lymphatics are always draining masses, right? Any skin masses, there's lymph nodes that drain, The sentinel lymph nodes are the first line guys. These are the first drainage lymph nodes. And then all of the lymphatics from the breast, from at least most of the breast, it filters into the axillary lymph nodes. If you on exam can feel this, you're done. You need an axillary lymph node dissection. That makes sense, right? Anybody who has palpable lymphadenopathy, they just need them all taken out. In anybody else, the approach, and if you've ever seen a breast surgery, then you'll be very familiar with this. The typical approach is you take out the cancer and make sure there's clean margins, and then you do a sentinel lymph node biopsy. How you know they're sentinel lymph nodes is honestly, it's also very easy. They usually put like a tracer or a dye in the cancer bed, and then they just use like a little like pen thing that's checking to see where the tracer dye went. And so all of the lymph nodes that it went to first, that are going to like light up the most, are their sentinel lymph nodes. And so they'll take all of these out and send them for like a quick frozen section. And if any of them show any signs of cancer, then we think about doing axillary. And by any of them, I mean any more than 2. So I know this is complicated. So it's just, it's not something that you necessarily have to like memorize. But axillary lymph node dissection, you do it in anybody who has palpable or clinical lymphadenopathy, and you do it in anybody who has greater than 2 sentinel lymph nodes that are involved. Radiation therapy, again, it's anybody who got a lumpectomy or a mastectomy that doesn't have a contraindication to radiation. So you might be wondering what some contraindications to radiation are. Honestly, the main one to think about it is if they already had radiation, because these are the patients that are going to get their risk of like secondary cancers from radiation goes through the roof, and like damaging to like local structures and that kind of thing. So if they can't get radiation because of like, let's say, active pregnancy or other things, those are other, reasons to not get it. And of course, if they don't want it. HER2, that's an easy one, right? They have to, have a HER2 positive. The only other fact to know about this is any tumor that's HER2 positive and is greater than 0.5 centimeters. Wow, that's a really small tumor, right? So if they are HER2 negative, or if they have a tumor that's less than 0.5 centimeters, then they don't get it. But anybody who's greater than half a centimeter is going to benefit from trastuzumab, pertuzumab, that kind of thing. Really small cutoff. Why? Because these patients, they have very aggressive cancers. Before the advent of trastuzumab, we knew that patients that got HER2 therapy would progress very quickly. So these are driver mutations that are going to be somebody who gets advanced cancers very quickly. That's why our cutoff is so low. All right. And then when we think about hormonal therapy, there's just three big buckets: premenopausal, low and high risk, and postmenopausal. So this is a callback to that algorithm that I used earlier. So our premenopausal patients who are deemed low risk, what agent do they get? Anyone?
They're low risk. This is
SARMs.
when we're thinking, yeah, tamoxifen, right?
Yeah, great. Grant, I know that you unmuted yourself too. So why don't you tell me what people get if they're high risk? Remember our soft trial?
I'm blanking.
It's okay. It's early in the morning. These are patients that get a aromatase inhibitor and ovarian suppression. And our postmenopausal patients, it's easy to remember as well because these are patients that, their only source of estrogen is, adipose and adrenals. And so they're the ones that get an aromatase inhibitor. And our last question that we ask ourselves for evaluation of therapy is, do they get adjuvant chemotherapy? Remember, adjuvant chemotherapy is only going to apply to stage 1 to 3 because these are patients who actually get surgery or metastatic treatment, and this is going to be for stage 4 disease, right? So the three main buckets for treatment we're going to talk about. For the most part, the three main buckets are people who have ER, PR positive, HER2 negative, and then there's ER, PR negative, HER2 positive, and then the last one, which is triple negative. Dun, dun, dun. Ah! Okay. Our general rule of thumb is that for cancers that are any of these buckets, really, is if they're less than 0.5 centimeters, they probably don't get chemo. So I'll just say no chemo. If they're greater than 0.5 centimeters in size, they will probably get chemo. The nuance here we're going to get into now in the next couple of slides. So I'll give you an algorithm. I'm just going to flash them on the screen for you guys so you can look at them later, okay? Because I think we're running out of, we're really running out of time. All right, so let's think about, I think the takeaway point is really the general rule of thumb is who gets chemo and not. And when we say chemo, it's typically an anthracycline. So things like doxorubicin, epirubicin, that kind of thing, plus a taxane. So things like paclitaxel, that kind of thing. For triple negative disease, this is when you think about platinums. And you could think about other agents like cyclophosphamide too. So again, I won't get into more detail, but so our bucket number 1, ER, PR positive, HER2 negative. First thing we do is think about the surgical and radiation and HER2 status. And then basically you block, if you're less than 0.5 centimeters, no chemo. Remember, they're all going to get endocrine therapy, right? They're all going to get endo. And if they're in this middle bucket, if somebody falls into essentially stage 3 disease, they always get chemo. And this middle bucket is who we check the oncotype on. Leave this up so you guys can look at it later. For ERPR negative, HER2 positive, it's even simpler, right? If they're less than 0.5 centimeters, no chemo. If they're greater than 0.5 centimeters, chemo. Always. And look at the cutoff here. It's different than before. And then for ERPR, like so essentially our triple negative, it's very similar, where no chemo if it's less than 0.5 centimeters. And if it's greater than 0.5 centimeters or any lymph nodes, always give them chemo. All right. Why do I have so much? So like we talked about, right? Stage 1 to 3 disease, you don't give them chemo if there's less than 0.5 centimeters. You give them if they're greater than 0.5 centimeters. And remember the complicating factor here is just you use the oncotype to decide their risk in people who are between 0.5 and 5, essentially. And when it comes to the agents, we do typically an anthracycline, taxane, kind of thing for first line. For stage 4 disease, if they're hormone positive, these are people who are going to get an aromatase inhibitor plus palbociclib plus an mTOR inhibitor. I would know this one because it's weird and different. And so people like to ask this. There could, in addition to all of this, if there's somebody who like had stage 1, 2, 3 disease and they were already on an aromatase inhibitor and then they progressed, there are people who will benefit from changing to fulvestrant. So you might see that sometimes. And then the other complicating factor is for bony disease. So if you have known bony mets, these are patients that are going to benefit from a bisphosphonate with denosumab. In all patients, this will decrease the risk of fractures. So you should always give them this. And then in hormone negative therapy, that's just like combination chemo, NOS. We'll just leave it at that. Return back to our summary slide. We don't need to talk about this because we already talked about it. And then I did have like a group activity, but maybe I'll just flash this up so you guys can do it on your own. And then I also had some mix-up questions that I'm going to flash up so that you could do it on your own as well. So the first one is this: pause your screen. And the answer is C. This, pause your screen. The answer is A. All right. This, pause your screen. Okay. Wait, wait a minute. I think I might be giving you the answers to the previous ones. All right. And I believe this one is D. The answer is D. Okay. Here's your take-home notes, and we're basically done. We did finish. It only took way longer than we thought it would, but I'll remain here for any questions. And thanks for joining. It looks like a lot of you stayed. So thank you. Feel free to leave, and then I'm also here if you have any questions.
Thanks, Navi.
Bye.
Thanks, dude.
Just kept going. What time is it? It's 9 o'clock.
Bro. I was like, is anyone going to stop him? I didn't know what time you had started because I joined late and I was like, what is